Hello, my name is Maytal Firnberg, and in this lecture we're going to review POCUS for shoulder joint effusions. Our goals and objectives for today are to review the indications, techniques and image acquisition, normal anatomy, pathology, pearls and pitfalls, and then briefly review an illustrative case. Indications for when I think to scan the shoulder are pain of the joint, swelling, trauma, decreased range of motion, or concern of dislocation. This last indication will be reviewed more thoroughly in a different lecture in this series. For our probe selection for this application, you may use either the linear high-frequency or curvilinear probes. The linear probe will give you a clearer image with higher resolution in smaller, younger, or less muscular patients, while the curvilinear probe will be a better choice in older, larger, or muscular patients. The curvilinear will allow you to better visualize the anatomy at greater depths for these larger patients. Throughout this lecture, you will see examples of images using both probes for comparison. Now that you have your probe in hand, position the ultrasound machine in front of the patient as seen in the picture to the right of the screen. Have the patient sit up nice and tall, with their arm by their side, in their lap, or reaching for the contralateral shoulder. Hold the probe transversely, with the probe marker oriented laterally towards the humeral head. Start along the upper arm and slide up the shaft of the humerus, past the humeral neck, until the humeral head comes into view. Remember to stay parallel to the scapular spine to ensure that you're not scanning the joint space obliquely. Once you have your joint space in view, fan from superior to inferior and back again to ensure that you are visualizing the entirety of the joint and not missing any effusions. Now let's review some normal anatomy. The shoulder is a ball and socket joint comprised of an articulation between the glenoid of the scapula and the head of the humerus. The glenoid fossa is a shallow socket joint and reinforced by a ring of thickened fibrocartilage known as the labrum. The joint is then encircled by the rotator cuff, a structure comprised of the tendons of 4 muscles that stabilize the joint. What we need to know for our POCUS indication is that the humerus and the glenoid intersect at the glenoid fossa, and this is where fluid can collect in joint effusions. As described before, one way to locate the joint space is to slide up the shaft of the humerus until you see the head of the humerus adjacent to the glenoid. Let's see how each of that looks broken down. Along this area highlighted in red, the humeral shaft can be seen with a classic bony shadowing in the center of the screen. When we reach the area highlighted in yellow, this can become confusing, as the angles of the neck of the humerus and parts of the scapula can trick novices into thinking they are at the joint space and seeing a dislocation or effusion. Sliding up to the joint space itself in the area highlighted in green shows the humeral head beautifully aligned adjacent to the glenoid of the scapula, with no fluid visualized in between. Now let's look at that as one clip all together. Here you see the joint space, the neck, and then the shaft of the humerus. Now that we've oriented ourselves to the normal anatomy, let's look at what the pathology looks like. On the left, we see the linear probe placed laterally on the posterior aspect of the shoulder. On the right, we see the bony shadowing of the glenoid and the humeral head with a thick stripe of black fluid in the joint space identified with an asterisk. Now let's take a look at the example of pathology using both the linear and curvilinear probes. Pay close attention to the differences between the resolution and view of the anatomy between the two probes. Here we see the linear. In this case, graciously shared by the Yale Penn POCUS crew, a 7-year-old who presented to their ER was found to have a shoulder joint effusion secondary to Lyme disease. Here we see the same joint effusion in the same patient, but using the curvilinear probe rather than the linear. Lastly, here is a still of the effusion using the curvilinear probe compared to what that same effusion, identified with the asterisk, looks like on MRI. The patient's Lyme titer and antibody results are shown in the upper left-hand corner. Alright, so we've covered a lot of information. Let's review some of the pearls and pitfalls. First, like in most musculoskeletal POCUS, we often have a contralateral joint to use for comparison. I often like to start with the unaffected joint to establish a baseline before moving on to scan a swollen or painful joint. Secondly, as for nearly all scanning in POCUS, positioning is key. Position your patient sitting upright, sitting up tall with their arms down by their side, in their lap, or have them reach for their contralateral shoulder to open up that joint space. Thirdly, make sure your probe stays parallel to the scapular spine to avoid scanning the joint obliquely. If you get lost, reorient your anatomy, trace the humerus back up to the humeral head, and try again. Let's move on to an illustrative case and how POCUS for shoulder effusion helped narrow a differential and helped guide management. I left a good amount of text on these slides for those using these lectures without the audio component. A 6-year-old female with no significant past medical history presents to the ED with 2 days of fever to 104 Fahrenheit, right shoulder pain, and a non-pruritic urticarial rash on her face, trunk, and arms. Her mother denies a history of trauma to her shoulder. There were no lacerations, abrasions, or insect bites. She had no cough, congestion, rhinorrhea, vomiting, diarrhea, chest pain, or abdominal pain. Given concern for MISC/infection, she had lab work and imaging done. On the right-hand side of the screen is a review of some of the lab work. Notably, her white blood cell count was elevated to 21,000 with a left shift of 82% neutrophils. Her CRP was elevated to 44, ProCal to 8.6. She had negative COVID PCR but positive serology. Her EKG was unremarkable, and her chest x-ray was within normal limits. She receives a dose of ceftriaxone at this visit for her fever and leukocytosis. She clinically improves in the ED with some Motrin, and she was discharged home. The differential that came up on this first visit was fairly broad, covering everything from myalgias secondary to viral illness, trauma, tick-borne illness, vasculitis, sepsis, etc. But this patient's story does not end there. A blood culture drawn from the initial ED visit grew MRSA, and the patient was recalled to the emergency department. Upon representation, the patient was found to have persistent fevers at home to 101 Fahrenheit and worsening right shoulder pain with decreased range of motion of the right arm at the shoulder. By this point, her rash had resolved. Her vital signs were notable for low-grade fever and mild tachycardia, but otherwise stable. On physical exam, the patient was uncomfortable appearing and crying with exam of her right shoulder, which had significantly limited range of motion, but no obvious deformity, redness, warmth, or swelling. Neurovascularly, she was intact and had no other joint swelling or pain elsewhere. The rest of her exam was unremarkable. So let's bring in the ultrasound. This patient was positioned seated on the side of the bed, hugging her mother to stabilize the shoulder. Alternatively, you can also have the patient sit upright and place their hand in their lap or on the opposite shoulder to access the joint space sonographically as described. Here is a still of one of the images that we got from this patient's shoulder. Here we have some labels to make it a little bit easier to see. We have the glenoid, the humeral head, and then a joint effusion identified with the asterisk. So what did we do with all of this information? Orthopedic surgery was consulted and looked at the POCUS images we acquired to perform a right shoulder arthrocentesis via the posterior approach in the ED. This yielded 3 cc's of purulent fluid from the joint space. The joint fluid came back with a nucleated cell count of greater than 100,000. The patient was started on vancomycin and ceftriaxone, and she was taken to the operating room by the orthopedic surgery team for an arthroscopic irrigation and debridement of the right shoulder. Inpatient, an MRI was performed, which unfortunately showed septic arthritis with a fluid collection deep to the scapula and osteomyelitis of the scapula. Orthopedic surgeon again took her to the OR and performed a right shoulder arthrotomy, irrigation, and debridement with incision and drainage of the abscess of the scapula. A peripherally inserted central catheter was placed for a 6-week course of daptomycin. Here are some important lessons I hope you take away from my lecture. Any joint can become a septic joint. Consider early POCUS to look for effusions in patients with fever and joint pain. The linear or the curvilinear probe can work for this application and is totally dependent on body habitus, but feel free to try both of them and see what you like better. Remember your anatomy and reorient to the familiar if you get lost. Stay parallel to the scapular spine with your probe oriented transversely. And lastly, fan through the entirety of the joint space to make sure you're not missing any fluid hiding. Thank you so much for listening to my lecture. I hope you enjoyed it and learned a lot. If you have any questions or clarifications, please email me at maytal.firnberg@gmail.com. Happy scanning!